Thank you, Dr. Amitabh. Thank you, Bengal Diabetes Association, for this privilege to give this talk. At the outset, it's a wonderful thing to come to Durgapur. I have passed through on a train once on my way to Jamshedpur, but this is my first time I've actually alighted over here, and I am certain that I might perhaps make further visits over here. So I'll start with a little bit of history. This is at the turn of the last century in 1900, wherein life in Travancore state, which is now part of Kerala, wasn't very easy. About 12 million Indians died of plague, and in Travancore and the Madras presidency, which was largely afflicted. So that is the map of Travancore, which ultimately became part of Kerala. And at that time, fortunately, there were two very emancipated rulers. One was the Diwan and the other one was the king, who decided at that time it would be important to send doctors and engineers to travel across India for training. So this is one particular doctor. His name was Kaidavanaparambil T. Jacob, who was born in 1889, and in 1960 he passed on. He studied at the Calcutta Medical College from 1910 to 1915, and he graduated and subsequently joined government service in Ceylon. He had 17 grandchildren, and there's a photograph of one of the obscure grandchildren at the bottom over there. So that's my grandfather, who probably spoke better Bengali than I ever will. Thank you. So I'll just start with a little bit. I'm going to focus a lot on our work on young diabetes over the last 20 years. And this is the Vellore birth cohort, which was started by a very visionary biostatistician way back in 1970. It's the oldest living birth cohort in India, and a lot of work has been done on it, particularly in connection with low birth weight and the metabolic syndrome. And this is some of the initial work which we had done over the last decade, looking at glucose levels in association with the leaner body mass. But if the muscle mass is good and the percentage body fat is really low, the glucose levels and the postprandial glucose levels actually tend to be good. So provided fat mass is low and the muscle mass is good, the glycemic trends are actually quite good. There's a lot of incidence data available from the Vellore birth cohort, and it's true incidence data. This is showing the prevalence of diabetes in Vellore at the age of 44 years. And you can see over there that the prevalence of diabetes between the rural groups and the urban groups is almost equalizing and is nearly the same. Previously, we were doing some coordinated work in genetics about a couple of decades back with Karolinska and with the Institute at Oxford, and we have looked at single nucleotide polymorphisms and their impact on diabetes. And a particular polymorphism, the ADCY polymorphism, has an association with impaired glucose tolerance. But this in the Indian group does not actually have an influence. So it's very important to understand our single nucleotide polymorphisms and the genes, and the impact may not be the same in the Indian population as to the Western population. We also looked at the FTO single nucleotide polymorphism, which has a very similar impact as the European one, increases waist circumference and increases the trend towards obesity and hyperglycemia. The MC4R has an impact on the height when it's a single nucleotide polymorphism, not a true variant, and they are bigger people who actually in fact have a lot of high lean body mass. Their muscle mass is good. This is some of the work which was coordinated by my research officer, Dr. Senthil, who is now actually settled in Oxford following his PhD. And this was done about a decade and a half back, looking at the prevalence of impaired glucose tolerance in children. And in boys aged 14 to 17 years, the prevalence of hyperglycemia or impaired fasting glycemia was nearly 20% before the age of 17 years. We also found an association with the maternal waist circumference and the hip circumference. Systolic blood pressure and diastolic blood pressure were increased more were in relationship to the mother's waist circumference. And if both parents had an increased waist circumference, the risk of the child being affected was almost 6 times. We also looked at the FTO in children, and we found that there was an association between the FTO locus and the waist-hip ratio in Indian adolescents. We were doing a lot of educational programs across the country, and this was through a World Diabetes Foundation related grant, where we trained a number of hospitals in rural areas across the country, looking at doctors and nurses developing integrated clinics in small rural hospitals. And based on that data we did work in Tripura, and this is way back in 2007, long before Indiab, and in Arunachal Pradesh, where we found that the prevalence of rural Tripura, a particular part, was really 9% diabetes at that point of time, with a significant quantum of overweight. 5% in rural Arunachal Pradesh in the year 2010. In Meghalaya more recently, the prevalence rates of diabetes aren't as high, but they have a very significantly increased prevalence of hypertension associated with leanness over here. So when we use the term lean, it's a grossly misused term. So I'd like to draw some definitions for this, and this is based on a Lancet article. Looking at which part of the world you're from, the cutoff for definitive lean, absolute thinness, is not 25, it is 19.2 for the South Asian population. And I do believe we can zoom in further. It may not be the same for a Kashmiri or Bengali or someone from Tamil Nadu. It may be all very different. So we really need to get better normatives for our population when we talk about leanness. And this is not the same cutoff which we're talking about for insulin resistance. For malnutrition, we mean a BMI less than 18.5. So we looked at the prevalence of lean diabetes in our rural population in Tamil Nadu, close to Vellore, 0.6% in the rural area and about 0.3% in the urban area. And this is talking about extreme BMIs less than 19 kg per meter squared. So when you have a lean person with diabetes, besides diabetes, type 1 diabetes, and slowly evolving immune-mediated diabetes, we have several other conditions which should be considered. And I've given them a different color because the ones in green I would say are fairly common. Lipodystrophy is actually quite rare. Wolfram syndrome is, well, it's not as rare as lipodystrophy and it should be looked for, but probably less common than the others. And then finally this condition which is called type 5 diabetes, which I will cover in greater detail. So how does one investigate a young person who has diabetes? There's nothing like a good history, a very good pedigree chart, which I'll give you a few examples, good physical examination, checking a fasting C-peptide level, and of course, if possible, doing a meal challenge to look at the postprandial levels, and the GAD antibodies, and an ultrasound of the abdomen. So those are the absolute mandated tests which should be done. The others, depending on the context, and I'll show you different examples of each of these cases. And of course, the genetic backup which we have, we've only one of 2 centers in the country which is routinely doing genetics for young onset diabetes, monogenic diabetes, as well as lipodystrophy as well. So I'll come to fibrocalcific pancreatic diabetes, which is still a very common disorder. Here is a classical patient who comes with abdominal pain, weight loss, but actually has normal bowel habits and no steatorrhea. And when we went back in the history, we found that he was actually avoiding a fatty diet. So lean habitus, no evidence of nutritional deficiencies. The stool elastase was extremely low. Normal is more than 200, indicating severe fat malabsorption. So previous maps have actually shown the distribution of this condition is largely in tropical areas, and 70% of them are male. So they have low C-peptide levels and they are generally insulin requiring. This was work done from Lucknow, showing in an age group less than 35, about 15% of patients in this group had FCPD. And this is, we were involved in the genetic work over here. Well, this is from Ish Bhatia's group at the STPGI in Lucknow. So it is still a problem, and we still see a lot of it in Tamil Nadu. I'm certain it is still there in West Bengal in addition. You should be looking for it. Anyone who's lean, low C-peptides, do an ultrasound abdomen, if possible do a CT. These are the other things that you have found. They have a very high prevalence of autonomic dysfunction, which can exacerbate the diarrhea and the weight reduction. They have micronutrient deficiencies in addition. And of course, be careful, because stool elastase levels can be low in patients who have had type 2 diabetes for more than 10 years with autonomic dysfunction. So that is something which we know, but of course the ultrasound or the imaging will actually prove or disprove FCPD. This was work done, and that's Riddhi, who has done some really fantastic work with us when he was working with us. This is a study which looked at hypoglycemia and awareness in patients with FCPD, comparing them to control. It's a very large sample size, and you can see over here that the higher the glucagon levels, the greater the risk of, the less the risk of hypoglycemia. And as time progresses over 5 to 10 years, the glucagon levels start dropping. But what is intriguing is that the glucagon levels are actually quite high, much higher than what are seen in control type 2s as well, quite high. And this is not expected when you have a fibrotic pancreas. The other thing, in fact, this was a study done before, and we were intrigued to find that the energy expenditure levels were high in patients with pancreatic diabetes, disproportionately high. And how does this happen? Glucagon actually switches on the mitochondria and increases burning of greater energy. So we actually found this, and then later on when we found the high glucagon levels, we connected the whole story together. But why are the glucagon levels high in the first place? And there are other studies which actually shown this as well. And perhaps with patients who wait much longer, the glucagon levels tend to drop. And I'll come to that. This is Sudeep's work on osteoporosis in patients who have fibrocalcic pancreatic diabetes, indicating it's associated with a higher excretion of stool fat more than vitamin D deficiency per se. So Shivendra was actually involved with this work, which is being sent for publication. And what he showed is, of course, this is all expected: low C-peptide levels associated, low pancreatic polypeptide levels, the K cells also being dysfunctional, with the GIP levels being low. But the glucagon levels were high, and they rose parallel to with a parallel rise in GLP-1 and oxyntomodulin. And so when we went back and looked, we found that in pancreatectomized dogs, and in other patients who had pancreatectomies in human beings, that the glucagon levels rose, and this was of extra pancreatic origin, coming from the proglucagon genome being switched on in the intestine, and therefore GLP-1 and glucagon rise at the same time. So these are our conclusions. It's an important disorder for you as practitioners, that besides giving insulin, you have to give pancreatic enzyme supplementation, and their energy expenditure being so high, their carbohydrate intake has to also be high, disproportionately, maybe as high as 2,500 or 3,000 calories per day, much more than what a type 1 diabetes patient would require. So I'll go next to the monogenic beta cell dysfunctional disorders, and those are associated with structural pancreatic disease. We have had a good geneticist, us, Dr. Aaron, who's been with us for the last decade and started off with the monogenic work way back in 2013, NGS related, next generation sequencing related work for the first time in the country. And we found initially that there was an increased prevalence of PDX1, ABCC8 and NeuroD1 in our population in the first few studies. This is a classical patient, just showing you how important it is to draw a good pedigree chart as well. Patient with GAD antibody negativity, a MODY1 who responds well to sulfonylureas in this case. So 2-month-old baby with frequent micturition. Below the age of 6 months, we should think of other causes and not type 1 diabetes. And this patient had a de novo KCNJ mutation, and this patient responds extremely well to high doses of glibenclamide. In a baby giving extremely high dose of glibenclamide, they do extremely well, they do not need insulin, and the diabetes may in fact become milder in due course. So the kind of sulfonylureas are also very interesting and important. The second generation sulfonylureas like glibenclamide, the glyburide is glibenclamide, glipizide and glimepiride are the ones which work better, and the standard drug of choice is actually glibenclamide. We were, in fact, the first to show digenic mutations in our study. It's very difficult to prove digenic mutations. You should do functional studies to prove it, but we can see the dose effect of two parents and the child who actually requires insulin, wherein the parents have milder disease over here. And this has been reported in the digenic disease database as well, wherein 3 of our cases have actually been cited in the digenic disease database as well. So Diagenic MODY does exist. So our work in patients who are pregnant, we asked the question as to why lean people who had a BMI less than 23 got pre-gestational diabetes, and could they have monogenic beta cell disease, MODY, as well. And we found that 18% had, this is a referral bias because we had patients who were on a lot of insulin treatment in pre-gestational diabetes, more than what you would expect in your population. But even then, it's important to think of monogenic beta cell dysfunction, because once they deliver, instead of giving them, if they have persistent diabetes, instead of giving them metformin, you may consider giving them sulfonylureas on a long-term basis. So our work, plus work from other parts of the country, from Dr. Mohan, etc., have shown that MODY2, or the glucokinase variant, isn't all that common, and there are other forms like MODY 4, 5, 6 and 12 which may be more common. And it's important to make a proper diagnosis, because the glibenclamide sulfonylureas work in several types, and the doses and of sulfonylureas can differ depending on the kind of MODY that you're dealing with. Here's another example, 16-year-old girl who came with mainly renal dysfunction more than diabetes, lack of menstruation, had normal pituitary hormones, indicating therefore that this patient does not have either ovarian failure or a pituitary disease. And it shows a bicornate uterus and a shrunken pancreas on the MRI. And this patient has MODY 5, hepatonucleotrophic factor beta, which is a variant in this particular patient. 20-year-old male, recurrent lower respiratory tract infections and steatorrhea, grossly underweight, and has severe malabsorption of fat, and that is the fat replaced pancreas that you can see on the CT scan. This patient has a CFTR mutation along with a SPINK1 mutation at the same time. This is work being done by our pediatric pulmonologist along with our genetic lab, showing that cystic fibrosis is indeed not rare as what was initially proposed in India before. And we need to think about this. Other causes for shrunken pancreas. 43-year-old lady, a nurse, who came with recurrent abdominal pain. This is acute pancreatitis. Then she progressed, developed calcification of the pancreas. I was treating her with insulin for almost 15 years. Then her daughter came with recurrent headaches with a high lactic acid levels, MELAS syndrome. And this is the MRI showing blooming of the basal ganglia. And all other causes were negative. Biopsy shows ragged red fibers on the muscle biopsy, and the genetic testing indicates a mitochondrial variant. And these patients require coenzyme Q. This can prevent neurological deterioration, does not have any impact on the diabetes. It's important to think of young diabetes. There can be phenotypically very heterogeneous. Different people in the family can come with different presentations when you have a mitochondrial disorder. So this is the panel now that we do for pancreatic diabetes, 11-gene panel, which we do for our patients. The CFTR and the mitochondrial are added on if all the others are negative, because they are slightly more difficult to do and have other demanding aspects when they are analyzed. So this is the profile. Once again, this paper has gone to press on the profile of various types of variants. Some are autosomal dominant, some are recessive, and they all have different phenotypic presentations when we are talking about them. Lipodystrophy is another disorder in young diabetes, which is much rarer. This is a 38-year-old lady with diabetes at 19 years of age, with hyposmolar symptoms, diagnosed to have type 1 diabetes. On examination, you can see the leanness and the prominent veins over here, phlebomegaly, markedly reduced subcutaneous fat as well. The striking feature is the very high triglyceride levels in this patient, and the C-peptides are also sky high in this patient. It was around 11 fasting C-peptides. This is the body composition, showing you the very low percentage body fat, but the head is disproportionately high. It's a kind of a pseudo-Cushingoid distribution of fat. This patient has partial lipodystrophy, and the variant is the laminin variant over here. These patients may have a reduction of insulin requirement by giving them pioglitazone. So many of them do well with pioglitazone. Unfortunately, this particular patient, the one on the top, is stunted, has severe insulin resistance and is insulin requiring. You can see the liver also is loaded with fat in this case, and you can see once again the percentage body fat is extremely low. This is a complete lipodystrophy. They need extremely high doses of insulin, 300 to 500 units per day. Prognosis isn't that great. They get cirrhosis before the age of 25 and many of them pass on. Lipodystrophy, as I mentioned, is a rare disorder, and I'd just like to acknowledge Asha for this particular case. And this series was written up by Ramya. We have a lipodystrophy panel. Interestingly, this is one of the largest series in the world, even though it's not huge. But what we found over here is that C-peptide levels are invariably elevated, moderately severe hypertriglyceridemia, body fat composition is disproportionately low. They always have grade 3 or 4 fatty liver. It's very unusual to have type 1 diabetes with a fatty liver. They're usually not there. So hepatic steatosis and laminin mutations are present in about 50% of these patients. Coming next to Wolfram's-like syndrome, 20-year-old gentleman who came looking like type 1 diabetes with polyuria and polydipsia, treated for a number of years. But the striking feature over here was the high sodium. And when you have uncontrolled sugars, you expect pseudo-hyponatremia. But the sodium was high. And you can see over here that the urine osmolality is low, indicating a dilute urine. So this patient has diabetes mellitus and diabetes insipidus at the same time. C-peptides were low and GAD was negative. So the sister has more rapid progression with visual loss, optic atrophy, once again diagnosed as type 1, but then the other things kicked in, seizures, and subsequently neurological neuraxis involvement, and passed on at the age of 26 years. So you can see over here the very gross hearing defect, sensorineural hearing defect, and also the OCT showing the thinned out the ganglion layer on the OCT. The atrophic pons in the brainstem is also prominent, and this patient has a Wolfram syndrome mutation. So it's very important when you have a young person, say they don't have ketoacidosis, their C-peptides are low, the imaging is normal. Once again, genetic things should come to the fore, and I'll give you some data on that. So by and large, this is a publication in JCM on Wolfram's, and you can see that they're largely insulin requiring. Occasionally you have a heterozygote who comes like an autosomal dominant and who may require oral antidiabetic agents, but it is very uncommon. So we now think about the Wolfram's-like syndrome, not the Wolfram's, but the Wolfram's-like, where they have milder disease and can progress to adulthood. There's another nice publication from UP which has shown the Wolfram syndrome predominance. So look at this graph. This is once again data which has just been sent for publication. You can look at the bottom line which shows the age of onset of diabetes, and then the optic atrophy comes several years later and the hearing deficit comes later. So just imagine at the initial phase in Wolfram's-like syndrome, you would not think of Wolfram's at all. So the importance of genetic testing therefore has been highlighted when you have patients like this. And the cost of genetic testing is coming down with reasonable rapidity. Why is it important to make a diagnosis? Because you can stabilize the endoplasmic reticulum in these patients. You can use valproate. There are studies, phase 2 studies, which have shown that valproate might help. One more medication which I should mention, which has been used in Leber's optic atrophy, is ibidinone. So that's another very useful medication which can be used. They can prevent the neurological progression in at least some of these young people. HIV lipodystrophy won't allude too much into this particular condition. It's a little different from the hereditary lipodystrophy. For one, the diabetes is usually mild. The insulin resistance is also not as severe as what you see in the congenital forms of lipodystrophy, and they usually don't have much hepatic involvement. So that's the thing. We now have an 8-year follow-up, and which should be published very soon. Generally, the diabetes is very mild and non-progressive, and the complication rates are not too bad. And these patients with HIV actually do pretty well when they are on ART and don't seem to succumb to early metabolic complications. Finally, I'll come to type 5 diabetes. This particular condition first reported in 1955, not perhaps first reported by 1955 by a British person in Jamaica by name Hugh Jones. But interestingly, you should read about Etienne Lanceron. I hope I got the pronunciation correct. He's a gentleman who described two forms of diabetes almost 200 years back. One was clearly type 2 diabetes, but the other was a lean form of diabetes where the patients had a fair degree of longevity. So it didn't look like type 1 diabetes, and they didn't succumb to ketoacidosis or any kind of catastrophic disorder. So the question is, did that condition with Etienne Lanceron, was it the so-called malnutrition modulated or type 5 diabetes? Was it actually more common, say, many years back? That is Dr. Bajaj, who literally pushed this into the WHO classification of malnutrition-related diabetes. I wish I had a few more photographs showing Samal and Tripati, who are very much part of the Eastern Belt and done a lot of work over here, and a very nice review written by Charlotte Bowama from Rwanda on this particular condition. So it was of course taken off the WHO classification, and subsequently following a physiological study which was done by our group as well as the group at Albert Einstein in New York, there was more attention driven towards this. So in April, just 3 months back, type 5 diabetes was declared as a potential condition which required study. This is not a new condition, it's not a rediscovery, it is something which we seem to understand a little bit more than what we did before. If you want to read up a bit about it, these are the upcoming publications in Lancet Global Health in a month's time, IGM in another month, the Scientific American publication 2023, and the Physiology publication which was published just 2 months back. So I'll just allude to what we know about the pathogenesis, and I think we know a lot about the pathogenesis, the pathophysiology, but we are not certain about the treatment. So the thing is, if you look at the risk for type 2 diabetes, you have a list of 21 conditions, and each of them has a well-validated reference. But there's one particular factor here which I'm going to give as an overlap phenomena which contributes to both type 2 and now what we call type 5 today. So inequity, global inequity, has an important impact on the evolution of type 2 as well as what I'm going to be talking of, type 5 diabetes. I've already talked about the thrifty phenotype. So the Barker hypothesis. If you're born low birth weight, your risk of accruing more body fat and developing obesity, hypertension and diabetes later on, provided you're well fed after delivery, is greater. And this has been seen in multiple cohorts across the world, in times of war, in times of famine. This is the Dutch hunger winter, wherein women from Netherlands had calories of 400 calories per day and subsequently had a very high risk of their babies when they were pregnant developing hypertension and diabetes several years later. These are figures from India. We do have a proportion of undernutrition, and we do also have a proportion of low birth weight in our country, which is fairly significant. Now, this is some of the work which was done about 15 years ago by our group, looking at individuals who are born low birth weight. We had a large birth cohort at the age of 20 years. We did 60 low birth weight and 60 normal birth weight at the age of 20. These are very laborious tests, the hyperinsulinic euglycemic clamp studies for looking at glucose insulin sensitivity, indirect calorimetry and NMR spectroscopy, and that was my resident that time, Dr. Spurgeon, who was actively involved with this. So what we found very interestingly was, with all these elaborate studies, there was no difference in energy expenditure, but between the two groups who both had the same BMI, very lean but muscular individuals at the age of 20, the low birth weight was shorter and lighter, had reduced muscle mass at the age of 20, mildly increased diastolic blood pressure, percentage body fat was slightly higher, and the low birth weight individuals had a habitual low protein intake, and this is not due to a socioeconomic difference. They had an aversion towards taking a higher protein diet. When we put them on a bicycle, and that's my community health professor colleague Venkatrava who actually did this study with us, we found that in a period of 2 months that the low birth weight group had an increase in muscle mass and a reduction in fat, and the energy expenditure actually improved. So low birth weight individuals do have an improvement in their muscle mass, and therefore the muscles do respond to exercise. And this is important from a therapeutic point of view later on when we think of lean individuals or malnourished individuals, that exercise is of some benefit. Roshan, along with our group, did this energy expenditure, did the measurement of micro quantities of fat in the liver and the muscle, and the low birth weight individuals have a very low content of fat on NMR spect. 20% have no fat in the liver. So the risk factor for fatty liver, etc., comes only when there's significantly increased dietary intake of carbohydrates over a prolonged period of time. It's not intrinsically there. Yarjanik's work from the Pune maternal health cohort has shown that the lean individuals have an increased risk of glucose intolerance and a progressive decline in insulin secretion. Now coming back to gross malnutrition, I saw in my last case of kwashiorkor about 40 years ago, and I haven't seen one, and I don't think most people see kwashiorkor nowadays. But people do see marasmus, which may be in some parts, in certain rural areas, may be endemic, but may be sporadic more often than not. So kwashiorkor has a survival disadvantage. The mortality rate is almost 50% when it happens. The marasmic ones live longer, and this is the work done by Michael Boyne from Jamaica, which has shown that those with severe acute malnutrition in early life, they have a lower birth weight when compared to the kwashiorkor individuals, number one. On follow-up, when they were given glucose tolerance tests, their insulin secretions were lower, and they had a greater tendency for glucose intolerance. These are the marasmic children. Now, interestingly, what has been seen in animal studies, besides having an insulin deficiency, which is probably due to epigenetic changes wherein insulin production is less, thank you very much, there is also a reduction in the effect of GLP-1. And this fits very nicely. We have now unpublished data wherein individuals with type 5 diabetes actually have low GLP-1 levels. And that is really unique because I don't know of a condition or form of diabetes where GLP-1 is grossly deficient. We all talk about treating patients who have diabetes with GLP-1 analogs, but they're not grossly deficient in GLP-1. Now, here are other animal studies which are done in Korea showing that there's a decline in insulin glucagon levels, and that's at a time perhaps when these are people who are perhaps born in an era when Korea was a very different Korea in the 60s or so. And from Ish Bhatia once again in Lucknow, that in the initial phase of subclinical malnutrition, there's a surge in insulin and then subsequently hypoinsulinemia occurs. So there's a lot of physiological information showing this. Animal studies showing clearly that in rats, the islet clusters are smaller. They have micro islets and less of the macro islets. So this is a map taken when the WHO classification came about, showing you the distribution of FCPD as well as that of the protein deficient diabetes mellitus. And that is an era when there was not so much technology. Even ultrasounds weren't ubiquitously available, leave alone C-peptides or GAD antibodies, or even for that matter glucose monitoring being present. The initial study done by Hugh Jones, whom I told you about in Jamaica, was a small number. But more impressive was the number from East Pakistan. This is, I think, Dr. Ibrahim, who was the founder of the Burdham Institute, way back in 1961, showing a significant number of underweight malnourished individuals who had a form of diabetes which was non-ketotic and quite common. More recently, in the last decade, we have publications from Jamaica, Uganda, and Ethiopia. And I'm going to focus on one study from Uganda, which shows the profile of this phenotypic group. Davis Qubix, a good friend of mine. You can see that the percentage body fat is around 13.5% in the underweight individuals. It's really low. And the C-peptide levels are also low. And these patients had their GAD antibodies tested, and type 1 diabetes was clearly ruled out. They were aketotic. And though this is a fairly large clinical series. Going back to the work done in All India Institute of Medical Science, and this is Pankaj Shah, must have done this work more than 3 decades back, published in JAPI. I always ask the question, why only JAPI for a clamp study? But maybe the data was kind of prolonged before it got published, showing that in these malnutrition modulated diabetes, there was no evidence of insulin resistance. But of course, they showed a higher insulin requirement, which is a little different. Work done by Mandeep Bajaj, who is Jaspreet Bajaj's son and the former president of the ADA last year, in Thai patients, showing that no evidence of insulin resistance. So there is no insulin resistance shown by 2 clamp studies. And then finally our study in 2022, when it was published, it was a long study. It took a very long time, almost 7 years, taking into account several groups compared. And I'll tell you why it took so long. We selected around 80 patients, and we had to probably screen more than 150 to get these patients, did genetic testing in all of them, and we compared type 1, type 2, lean controls, overweight, low BMI individuals, and obese individuals as well. We did imaging of the pancreas and all, and ultrasound and an MRI was done in all these patients. They all had body composition studies. So by the time you go through that entire process, many people say, no informed consent, we can't go through the study. So we had quite a few dropouts initially. All of them had a hyperinsulinic euglycemic clamp study. So that's about 80 of them. And this is a very elaborate pancreatic clamp wherein we give glucagon, somatostatin, and growth hormone in addition to clamping the glucose for a period of totally 8 to 12 hours. So these are the BMIs, as you can see, the different groups. Now, what was seen was that the insulin levels were low, not as low as type 1, but much lower than the type 2s. This is the pattern of the glucose, as you can see over here. Once again, the pattern of glucose in type 1s, and you can see the patients who have our lean diabetes over here, a much flatter curve compared to the type 1s over here. And this is the hepatic glucose disposal, showing that their hepatic glucose disposal is very different from type 2, and therefore they have lower hepatic glucose disposal, low insulin production, low percentage body fat, and no evidence of peripheral insulin resistance. So it is a different phenotype that we are dealing with over here. This is, and so let me just summarize also the dietary findings. They ubiquitously had low protein intake, and they also had micronutrient deficiencies, particularly that of zinc. And we haven't published that, but the zinc deficiency is pretty profound in these individuals as well. A year later, there was a review in Scientific America talking about this particular article, and this is our more recent article in Physiology which has been published. So, in summary, it's a disorder with no autoimmune or standard genetic etiology. They have low BMI, poor insulin secretion, hepatic glucose output being low unlike type 2 diabetes, very low hepatic fat content, percentage body fat very low, and differences in their dietary preferences as well. The Lancet Global Health article will also talk about this, and the IgM review will also come out in the next 1 month. So this is the cartoon in the Lancet Global Health article telling you preconceptional undernutrition subsequently with overnutrition in the postnatal phase leads to type 2 diabetes. Preconceptional undernutrition and subsequent undernutrition postnatally leads to type 5 diabetes. So that's basically the model that we are following here. Now, there could be apples and oranges, there could be overlaps, you could have variegated patterns. So it's all up for grabs as far as understanding the disease better. So here's a classical case, 20-year-old gentleman, fasting hyperglycemia, grossly underweight, from our rural area, about 10 kilometers from our medical college campus. Weight loss, important thing is the birth weight over here which we got. Nowadays, when I sit in my outpatient, I always ask my young people who have diabetes, what is your birth weight? And of course, most young men don't know their birth weight. So I'll say, please call your mother and find out the birth weight. So it's a pretty useful tool which you can employ as well. Despite that, of course, from rural areas, many of them will not know their birth weight. But if you do know it, it's useful. Their BMI was low and no other clinical findings. This is the lipid profile, as you can see over here, and glucose levels of 12.6 A1C. We controlled the glucose of the next 6 months before we did the clamp studies. And the patient gained 1.5 kilograms over the next few months. We've ruled out malabsorption. The elastase levels were normal, and that's after correcting the glucose for 6 months. We found the C-peptides were low in the fasting state, and postprandially C-peptides showed a mild surge. There's no evidence of fatty liver on the ultrasound. Again, the DEXA done after 6 months showed percentage body fat of 17.4, which is very low. So the genetic analysis, this is not mandated, but this is part of our research study. A 62 gene panel was negative. So lean, young onset, non-autoimmune, fasting insulinopenia, normal pancreatic structure, low total body fat, non-ketotic, no hereditary pattern, qualifies for type 5, controlled with sulfonylureas 3 mg per day. So what is the pattern? Of our series of lean diabetes patients, 50% do not need insulin. And that is the good news, that many of them could be controlled with oral anti-diabetic agents. Now, I was asked this question as to why or how. What is the mechanism they work? It's like, is there some epigenetic change in the beta cell membrane which is enabling them to respond to other oral anti-diabetic agents? We don't know the answer to that question. We only know the good news is when you give them OADs, they can stay very well controlled, they have a sense of well-being, and they never develop ketoacidosis as well, and they put on small amounts of weight. We have had a follow-up now over 6 years to 7 years of some of these patients. Despite reasonably good calorie intake, their weight gain may be at max 3 to 4 kilograms, so they don't become obese. So insulin therapy in 50%, OADs. We know metformin works through various mechanisms. Even though these patients are lean, low-dose metformin we think is an option, and they don't seem to lose weight. So, but this is all up for further research. High protein diet, we do believe, will stimulate beta cell function. We know that certain essential amino acids, arginine, isoleucine, can actually stimulate insulin production. Will it cause partial reversal? Who knows? And we talked about resistance exercise and aerobics, improving glucose transport. Once again, therapeutics is an area which really needs to be researched in detail. So we need to relook at the diagnostic criteria, and we are in the process of actually doing epidemiological work, like how you have Jones criteria for rheumatic fever or for criteria for diagnosing Marfan syndrome. We need to figure out what are major and minor criteria. But the spread of common factors, I'm not saying we need to have everything in everyone, but the essential things is ruling out. Therefore, C-peptides, GAD antibodies, and an imaging of the pancreas is mandated. These tests have to be done. Beyond that, you have to kind of match and mix your other findings to try and make a diet. But we are not on solid ground to make diagnostic criteria. Now, if someone can tell me what the diagnostic criteria for diagnosing type 2 diabetes is, you'll get a gold medal for that. Maybe a couple of the endocrinologists in the front can tell me as well. So that was that, and this is how we investigate, what I already talked about, and the mandated tests which we definitely need to do in these patients. So one of the arguments is, could this be SIDD? You know that type 2 diabetes, according to a Swedish group about a decade back, has been divided into 5 clusters. So you have this group called SIDD, so-called severe insulin deficient diabetes. Now they do have lower C-peptides, but they're not grossly C-peptide insufficient. And I don't like the name severe insulin deficient diabetes, but anyway, that's the name that it's been given. Nor is it AD or WHO classified or anything of that sort, but it's a good concept to divide type 2 into various forms, more insulin resistant, less insulin resistant, etc. So we looked at some of the data. This is the study from Mohan showing the SIDD cluster, their median BMI is 24.9. So there are some of them, if you look at the standard deviation, who have a very low BMI, but they are not extremely lean like our patients. And their C-peptides, they didn't actually have routine C-peptides done in these patients. So, and I'm sorry, this patient, this group had C-peptides. So you can see the C-peptide measurement at the bottom of 0.8. They're lower, but the BMIs are on the higher side. This is again another study which was, kind of pan-India, involving many people from across the country. Once again, you look at the trend is that the BMIs are not that low in SIDD. So this appears to be very different from SIDD. Once again, I'm not saying that there can't be overlaps. There could be overlaps. It can all happen. So type 5 is a distinct metabolic entity with the basic features which I described: deficiency of insulin, no insulin resistance, low body fat content, normal pancreas. It has a unique pathogenesis with probably a double hit nutritional problem. We need to understand the differentials of all other conditions, and of course diagnostic algorithms is something which we should be working towards. So in summary, these are the conditions we should think of when we see a young person with diabetes, the differentials for type 1 and slowly evolving immune-mediated diabetes. We should also understand that there are several nutritional and social issues can impact the evolution of diabetes. I'd like to thank my funding agencies and also a number of my colleagues whom I've worked with. I wish I had all the photographs to put together, but some wonderful people who we have worked with over the years, and many I would like to acknowledge. Thank you for your patient listening.